Hello everyone, I am Dr. Sabnam Parvin, consultant in Reproductive Medicine and Surgery in Genome Fertility Centre, and today we are going to discuss about recurrent implantation failure, which is most commonly known as repeated IVF failure, and how we deal with it. So before going into the pathology, let's see what implantation is and how pregnancy is obtained. So every month in a woman's body, follicle starts growing, and inside it the egg also grows and matures. When it reaches a particular diameter, under the influence of various hormones, it ruptures and the egg ejects. The egg is taken up by the tubes where it meets the sperm and it leads to the formation of an embryo. Now the embryo stays in the tube for a few days, after which it enters into the uterine cavity. In the uterine cavity also, it roams about for around 1 to 2 days. It tries to find a suitable position where it wants to attach, and once it has found that area, it goes and attaches and it embedded inside it further. So this phenomenon is known as implantation, as we can confirm when we do an ultrasound after 3 weeks of embryo transfer and we see a gestational sac within it, the implantation is confirmed. Now, what are the factors which affect a proper implantation? First of all, a genetically normal embryo which is working well, which is able to do all the physiological functions, that is required for the success of an IVF. Now, it again depends on the egg quality, the sperm quality and the genetic makeup of the embryo. Second of all, we see that the endometrium, whether it is receptive enough. So the endometrium has to prepare itself, it has to undergo a number of physical changes, molecular changes in order to prepare itself for the receiving of the embryo, and this is required for proper implantation. Thirdly, we see that the endometrium is receptive only for a limited period of time, which is known as implantation window, and only when the embryo and the endometrium communicates between this time frame, then only implantation will occur, pregnancy will occur. Finally, there are two other factors like the age, which will determine the egg quality, the sperm quality, and the uterine abnormalities will also increase with age. The genetic abnormalities will also increase with age. Finally, in case of IVF, the embryo is formed outside the body. So the lab conditions, the environmental conditions, these are required for improving the implantation potential of the embryo. Going on to the question, what is recurrent implantation failure? So there are various definitions of recurrent implantation failure. The most common being that in a couple where the woman's age is less than 40 years and at least 3 embryo transfers has taken place of at least 4 good quality embryos and still pregnancy has not occurred, this condition is known as recurrent implantation failure. What is the incidence of it? Now, it is difficult to calculate the actual incidence because of the varied definitions, the varied causes. In my clinical practice, I have seen that around 10 to 15% of the couples, they may suffer from repeated IVF failure. Now, what could be the causes of recurrent implantation failure? So, there let's divide it into two factors. One is the embryo factor and the uterine factors. In case of embryo factors, first we have to look into the factors which affect the egg quality, like the age. Then during stimulation, if we see that the number of egg that we retrieve, it is too much or it is too less, in such cases the oocyte quality or the egg quality may be affected. Now there are certain hormones which determine the egg quality, like AMH hormone, FSH, LH hormone. If we see any abnormalities in this can help us in understanding the egg quality and the egg quantity. Finally, how the ovaries are responding to the various hormonal injections, that is also through that we can understand the egg quality of the particular woman. Going on to the sperm parameters, many a times the sperm parameters may be normal, but still there may be sperm DNA breaks which may affect the embryo quality. Then going on to the uterine factors. Now in case of uterine factors, there may be congenital anomalies which may affect the receptivity of the endometrium, and there are again acquired certain abnormalities like endometrial polyps or chronic infection, endometritis, thin endometrium, adenomyosis, fibroid uterus. All of this could be a cause for recurrent implantation failure. Now, how does the endometrial microflora that affect implantation? Now, it was a popular belief before that the uterus is sterile and there is no bacteria inside it. The vagina has the healthy bacteria. But current concept says that the uterus also has some healthy bacteria and which is required for conception, for fertility. And any time when there is infection or this microflora, it is affected, then implantation may be affected. Going on to the next question, how does tubes affect the IVF success rate? Now, it is very commonly seen that tubes, are not required for an IVF treatment, because most of the times what happens is tubal pathology. Whenever there is tubal pathology, we can go for IVF. But what happens is, if fluid is accumulated within the tubes, then during embryo transfer, if these fluids they enter into the uterine cavity, then it may either flush out the embryos or it can be toxic for the embryo as well as the endometrium. So how do we investigate these patients? Like, how do we find out what is the culprit? So first we have to see, mostly what we do is during any IVF cycle, before the cycle commences, we go for the egg count, the AFC, the AMH and the hormonal tests. But even when we see that there is repeated implantation failure, when the IVF cycles the results are negative, in such cases we can go back to the tests and see where we have missed something, or if some tests have been omitted, or we can repeat the tests again to see whether the quality is affected to some extent. Secondly, the sperm quality. Now most of the times the parameters is what we see. Now it's not routinely recommended, but we can do the sperm DNA integrity testings, which can give us an idea as to the cause of this repeated failure, which can also help in diagnosing the DNA fragmentation index, in case of which we can prescribe certain lifestyle modifications or certain medications which can help with the IVF results. Third, it has been seen that the parental karyotype, the chromosomal abnormalities, are seen to be more in recurrent implantation failure in these patients. Therefore, we can go for a karyotype for both the partners. Finally, we have to investigate the uterine cavity where the implantation occurs. So there are two methods, one is invasive, one is non-invasive. In case of non-invasive, we can go for the 3D ultrasound, the saline infusion sonography, and in case of the invasive method, we can go for a hysteroscopy. The best part about invasive method is that in hysteroscopy, we can treat whenever there is an abnormality, we can treat the patient in the same setting. Going on to the newer modalities of investigation. So we have investigated the embryo factors, the uterine factors, but before this I have explained about the implantation window. So sometimes what happens is, due to certain conditions, the implantation window may be displaced. Either it closes early or it is delayed. Now, to determine the personalized implantation window, there is a test which is the endometrial receptivity array, which can be done via endometrial biopsy, and during the time when we want to transfer the embryos, we can take the biopsy during that time and we can see whether the endometrium is receptive towards the embryo or not, and depending on the results we can get a personalized embryo transfer timing, according to which we can do the transfer. Now this is again still the results are controversial. So some research says that it improves the IVF success rate, whereas others show that they don't improve. So this can also be used in selective patients. There are other two tests. One is EMA and ALICE. These can also be done. These are tests which determine the microflora biomass. So that can be done to determine whether there is any chronic endometritis or not, or whether the biomass is affected or not, and therefore we can treat these conditions and then go for an embryo transfer. Now coming to the treatment part. So what are the things we can do for treatment? First of all, improving the egg quality. How can we do that? In case of aged oocytes, we know that the energy content decreases and the toxic materials increase in these cells. So we can give energizers like CoQ10, and antioxidants can be provided for these patients. In order to recruit more and more follicles to improve the egg count, we can give dehydroepiandrosterone. And then to increase the ovarian response, there are adjuvants like androgens and the growth hormones. So these are the adjuvant therapies that we can give in order to improve the IVF outcome before or during the IVF stimulation cycle. Now, in case of sperms, what we can do is we can give antioxidant therapy for 3 to 6 months before the IVF cycle commences. There are certain newer sperm retrieval methods by which selection can be done of the sperms which are better without the DNA break, or which are physiologically better, and that will be able to improve the quality of the embryos. Finally, if there is no other option, then we can also directly retrieve the sperms from the testis, which is going to decrease the sperm DNA damage, and these sperms can be used for IVF. Then again, in some cases, like we have seen that the embryo is normal, but the outer covering, which is known as the zona, it is either hardened or it is thickened. In such cases, we can do a procedure which is known as zona hatching, in which via laser we make a small hole or we decrease the thickness of the zona, and this helps the embryo to hatch and implant. Going on to the uterine abnormalities. So in case of where there are congenital abnormalities, like there's a septum, we can resect the septum. In case of polyps or myomas which are jutting into the uterine cavity, we can remove those. In case of synecdoche also, where there are adhesion bands, we can remove that. In some cases, we can give medical management like chronic endometritis or adenomyosis. So definitely, if we are finding any uterine abnormality, we have to treat them before we go ahead with the embryo transfer. So there are certain newer modalities in treatment as well, which are not approved to be used regularly, but these are still in the research phase and we can use in some selective patients. Like in case we are doing an embryo transfer, we can use embryo glue, which is basically hyaluronic acid, which helps in implantation. Many studies are there where intrauterine HCG is being administered before embryo transfer, which is shown to improve the implantation rates. Again, there are certain new technologies which are coming up, like for example the time lapse imaging incubators. In these, the embryos are kept in a stable condition, and we can continuously monitor the growth of the embryos, which helps in seeing the dynamics of the embryo, and therefore this could be in future, it could be a good modality to be introduced into the lab system if the cost effectivity and the cost benefit ratio is found to be better. Then the last newer modality that we see is PGTA, in which the embryos that we are going to implant, we take a few cells, we see the genetic composition of those cells, and the ones where the embryos are genetically normal are transplanted. In elderly age group patients suffering from repeated IVF failure, in these patients we see that PGTA has shown improvement in the success rate, and therefore this is also a work in progress, where in future we might be using it regularly in such kind of patients. Finally, before we start our next cycle in this patient, what are the modifications or what are the adaptations we can do as a clinician as well as an embryologist? What are the changes we can do in the IVF cycle? First of all, we have to go through all the cycles that has already taken place, and we have to determine a properly designed ovarian stimulation cycle, which is going to improve the egg quality as well as the number of eggs which can be retrieved. So we can give the various adjuvant therapies that I have already spoken about, and that can improve the egg count as well as the quantity. Finally, the role of the embryologist will be to scrutinize the embryos well to see the quality of the embryos, and if there are adequate number of embryos, then we can take them to the blastocyst or the day 5 stage, which definitely has a better implantation potential than the day 3 embryos. So this was an at a glance of recurrent implantation failure and how we can deal with it. So if you have any queries, I would be happy to answer them. And thank you for your patient hearing.